While this commonly is heard with bundle branch block, it may occur in many individuals with perfectly normal hearts without block. Reduplicated second sounds at the base are found with normal and with abnormal hearts. Many patients with mitral stenosis and a loud pulmonic second sound will have that sound reduplicated, but it is the accentuation of the sound and not its reduplication that is important. Incidentally, this loud pulmonic second sound of advanced mitral stenosis is most often heard not in the pulmonic area of the normal heart, that is, the second left interspace, but rather down along the left sternal border, commonly as low as the fourth interspace. A ringing aortic second sound has a character which is unique. This is quite different from an accentuated aortic second sound. This is simply louder than normal, and it has none of the overtones or harmonics which give a ringing second sound its musical quality. It is of some importance because it represents dilatation of and a change in the character of the wall of the aorta, either from syphilitic aortitis or from a long-standing systemic hypertension with arteriosclerosis. A question which is often asked is, in the mitral area, how do you tell which is the first and which is the second heart sound? Well, there are a number of ways, which include palpating the apex thrust when this is present, and considering that this is synchronous with the first heart sound, or, when the apex beat is not palpable, to feel the carotid pulse, and to consider this synchronous with the first sound. Unfortunately, this method requires doing two things at once, namely, feeling and listening, and a much simpler procedure is to listen at the apex and compare the interval between the two sounds. With a regular rhythm, this is easy because timing is comparatively simple, and because the interval between the first and the second sound is never as long as the interval between the second and the next first heart sound. With disturbances of rhythm, such as irregular fibrillation, however, this may be a bit more difficult. But of the two methods, timing by just listening is simpler and will result in less error. Dr. Levine has suggested another trick of the trade, which sometimes is of value. Listen at the base, where it is easy to identify the second sound. Now, inch down toward the apex, tracing this sound down to the mitral area. Here is a second sound in the third left interspace. Here it is in the fourth interspace, somewhat laterally. And here it is in the mitral area. presystolic murmur of advanced mitral stenosis may disappear, most often with rheumatic reactivation or with severe heart failure. And under these circumstances, it is of great value to be able to recognize a sharp mitral first sound. As previously mentioned, this is frequently not a loud mitral first sound, but it always is short and high-pitched. Turning the patient in the left lateral position after slight exercise may give you information which does not present itself with the patient at rest in the supine position. This is particularly true of mid and late diastolic murmurs and of a sharp mitral first sound. Sometimes the same result will be obtained by listening to a patient with aortic valve disease in the upright position with breath holding. And to note the effect of exercise on the behavior of a heart is worthwhile. First, an unusually sustained fast rate may be associated with lessened cardiac reserve. And second, if a patient is receiving digitalis, one may be able in part to gauge its effectiveness by the fact that the heart rate does not increase as it normally would. Most often, faint heart sounds at the apex are not the result of myocardial damage. Several exceptions are, first, that with pericardial effusion, heart sounds, which were clearly audible, become less loud and sometimes disappear altogether. And, secondly, that with a combination of faint heart sounds and a forcible apex beat, one usually is dealing with serious myocardial disease. And thirdly, that vasomotor changes with a drop in blood pressure may change the degree of intensity of sounds at the apex, so that sounds which were of normal loudness may, with a simple attack of fainting, actually become inaudible. The degree of loudness, or the comparison of the two sounds at the apex, is, of course, not necessarily indicative of heart disease, because at times the second sound in the mitral area may be louder than the first sound even in normal hearts. And not infrequently, with valve damage, the first sound may be replaced by a murmur. Disturbances of rhythm can be accurately recognized by auscultation about 85% of the time, but in the remainder, this must be determined electrocardiographically. This holds particularly true of the paroxysmal tachycardias, when to know what type one is dealing with many times dictates both therapy and outlook. Here, for example, is an illustration which certainly sounds like a paroxysmal auricular tachycardia. But this with a paroxysmal auricular flutter. Paroxysmal ventricular tachycardia many times is slightly irregular in its rhythm, but this is certainly not always so, and if treated as a paroxysmal auricular tachycardia, a patient may die. In contrast, however, auricular fibrillation can almost always, but not every time, be recognized just with a stethoscope. The total irregularity of this rhythm, invariably made even more irregular by exercise, characterizes it and distinguishes it from another very common irregularity, namely premature beats. These may occur occasionally, or they may occur very frequently. But usually fewer come through after exercise, unless the heart is severely damaged, when it is a good thing to remember that they may actually increase in frequency after exercise. Another disturbance of rhythm, especially important when a patient is receiving digitalis, is coupling. This is a rhythm consisting of an alternation of normal and premature beats, and with it, as with premature beats generally, both the first and second heart sound in the premature may be heard, as in this illustration, Well, say now that you have repeatedly tried to determine whether heart sounds are normal or otherwise, that you recognize different types of murmurs and disturbances of rhythm. Will anything else help you? Well, here are a number of suggestions. First, try hard to listen for one thing at a time and listen with your eyes closed. Be comfortable, relaxed, and listen from the right side of the patient. If you sit on the bed, the nurse may complain, but don't let that bother you. Second, have a system and seek for information step by step in every patient you examine. A good scheme is to have the patient lie down, listen at the apex for rate and rhythm, paying attention to nothing else. Then listen for heart sounds, training yourself not to hear disturbances of rhythm or murmurs while doing so, and then listen to murmurs in the same fashion. Next, turn the patient in the left lateral position after a bit of exercise, depending upon his condition, and listen at the apex for sounds and murmurs, again, particularly while the heart is coming back to its pre-exercise rate.